those of you who have just joined us, my name is Victoria Beale. I'm here supporting the organisers today, Euronox, for this wonderful symposium. Thank you for coming. So our next speaker, you're going to enjoy this one, okay? Dr. Roger Zhang. So he's a Doctor of Philosophy with a PhD of Computer Engineering, Image Scientist and Director of Clinical Affairs, Koning Corporation. Dr. Zhang leads R&D at Koning Corporation, focusing on cutting-edge imaging technologies for early cancer detection, which is amazing. So thank you. Please welcome to the stage Dr. Roger Zhang.
Thank you, everybody. So today my presentation is about Koning breast safety. Some of you already heard David George's, he gave a little bit teaser before the launch. So I'm the one that's present a little bit more topic that we talked about when you first see the breast safety. So start. So it's a system overview. You already see some of the images on the display on the right. So overall, this is the system, how the system looks like. And so basically the table allows the patient to lie prone and the breast drop into the opening in the middle of the table. And also the table is slightly concave to maximize the chest wall coverage during the image acquisition. So the table itself is only 65 centimeters high, so allow an average height woman just to sit on it and easily mount herself onto the table. And of course, you can use a step stool for some patients that may be a little bit difficult, but overall, the positioning procedure is very quick and acceptable by both the patient and the technologist. And also, when needed, the table can be raised to about 1.4 meters from the ground to operate on the breast for like an image-guided biopsy or other procedures. And so the whole system includes a scanner, 1, and 2 is a control console with LED gas, and a power unit, number 3. So typical, the room is 10 feet by 14 feet, and so the system can just be easily rolling, and to be fully functional, installation takes about 1 or 2 days. So the room does not need special shielding or anything because the system itself is already self-shielded. So that's the system. You see another picture before. So also when the door is open, can be open from both sides. The table can be lifted, and that's the mode to image-guided biopsy. And this is how the patient is positioned on the table. And this animation shows when the patient lies prone on the table, and the see-through view shows that how the detector, flat panel detector, and the X-ray tube is rotated around the breast. So as you can see that it's a half cone, that's what we call cone beam, so no radiation shoots out, so only the breast gets exposed. That's why it's low dose. So the table is raised, so we have a separate accessory mounted underneath the table, so that allows for a grid and backplate system to allow image-guided biopsy. So this procedure is very similar as MR-guided breast biopsy, just much faster. So the whole procedure can be done between 15 and 20 minutes from the patient lies on the table and off the table. And image display, and it's a CT image. So we display in basically it's in anatomic planes, typically transverse view, sagittal view, and coronal view. And also we provide a full 3D image for 3D localization or a better view of the spatial location of any lesion. So this is how the image is displayed in our workstation. And when radiologists review image, that's for single series. So this is how the image will be displayed. On the top left is the transverse view. Top right sagittal view, coronal view, and 3D MIP. So you can either for the 2D views, you can fly through the whole breast thickness, and for the 3D MIP, you can rotate in any direction. This is just a video, so I only rotate in one direction, but actually you can freehand rotate it. So when we have a multi-series, sometimes the multi-series can be a pre-contrast and post-contrast image, side-by-side comparison. Sometimes it can be the current image versus prior image, or left and right, or even biopsy series, and we can display it in this multi-series side-by-side views. So something like this is the left and right, and you can see that this is for implant patient, and so this multi-series for the image-guided biopsy procedure. And it's very easy because it's a 3D isotropic image, so we can do this crosshair localization. So whenever you see anything in one view, you can quickly click the crosshair, and you will bring the same spatial location and display in other views. And so image characteristics. It is an isotropic high resolution image. We can achieve the standard resolution mode. We only scan the breast once, and the software can reconstruct in the standard mode or high resolution mode. In the standard mode, the voxel size is 0.19 millimeter, and in high resolution mode, it can go to 0.1 millimeter. And if we compare to another 3D modality like the breast MR, it's usually times higher resolution than breast MR. And so I listed in 1.5T and 3T the spatial resolution of MR. So you can see that we are much higher in the spatial resolution. I have to point out that this KBCT achieved this by only 7-second scan, and MR achieved this and by usually you do a full protocol scan of the MR image. So this is a quick comparison of how the higher spatial resolution can bring us, and it allows the KBCT image to differentiate the smaller structures in the breast. And in this example, you see that this is the exact same breast. The breast MR identifies enhanced this lesion, and CT detect the same lesion, but you can differentiate it's actually multiple smaller enhancements along the duct. So that may, in some circumstances, like in this one, this is another case, and you can differentiate this. This is a primary lesion and a secondary lesion, but the MR only gives a large enhanced mass. So that gives us the ability that in some cases you may, using KBCT, may come up with a different treatment plan compared with MR. Now, another imaging characteristic is that there's no overlapping tissue. So this here is a mammogram, 2D mammogram of the lesion, and you can identify there's a primary lesion in here. And if we look at the same image, same KBCT, same breast, the KBCT image, and you will identify that. Yeah. So this is plain. So once you go through the slices in the coronal view, first you see this high density mass. This primary mass that's by the arrow. Then this secondary mass pop up, also in the higher density. This is without contrast media, and a higher density compared with the normal tissue, and you can tell this also something that you want to pay attention. And what's next? You may order a contrast image, and you may use an ultrasound to confirm, and then there are tools for the further evaluation of both of the lesions. But I want to point out that this you cannot get from a mammogram. And mammogram usually the tissue overlap basically blocks all the possible ways that you may discover this secondary lesion. And so this is another example of no overlapping tissue. And in this case, mammography reported focal asymmetry, while in KBCT, in the same location, you see multiple oval-shaped, well-defined margin masses in the same area. So what this can bring you, and you may eliminate further steps of this patient, or directly, if this show different morphologic characteristics, you may go further to over contrast for further evaluation. But anyhow, then you get more information from the 3D non-overlapping image compared with 2D mapping. So volumetric measurement. Because this is 3D, then we have tools that can do the segmentation. So we can segment out the found lesion, and the software can quickly calculate the volume of that lesion. And we, meanwhile, and we have like a color mapped something, and then we have this tool that overlap a clock face mask that can easily identify this the clock face location of the lesion, and we have tools that can measure the lesion, the distance of the lesion from the nipple. So we combine all these features, spatial location, distance, volume, that will help a lot both in diagnosis and preoperative evaluation. And in some cases, if mastectomy is inevitable, and we can help measure the volume of the whole breast, and that may be useful for post-surgical reconstruction to reach the similar size of the breast compared to the contralateral breast. Patient experience. The KBCT scan is a pain-free scan. The patient lies prone, there's zero compression. Compared with mammography, which is usually has like larger than 80 Newton of the compression force, and at least twice in CT and low view for both breasts. And KBCT has no compression. In our study in 2019, basically collect the questionnaire from over 400 patients, shows that the KBCT is significantly more comfortable than mammography. Basically, it's less pain, better experience, definitely will improve patient compliance with the whole breast imaging and workup. Imaging speed, 7 seconds per scan. If we are counted for a non-contrast exam from the time patient walk in to the room and walk out is usually less than 5 minutes. If we do contrast, the procedure can be done in less than 10 minutes. Compare with mammogram exam, and every time compress the breast and take an image, then compress again, take an image. That's about the same time as a non-contrast KBCT scan. And if we talk about breast MR, full protocol, at least like 40 to 60 minutes. Even abbreviated MR, at least the table time is like 20 minutes or so, based on the literature. Breast coverage. Koning breast CT covers a wide range of breast sizes. So it's post-mastectomy breast with a tissue expander, and smaller breast and large breast up to 19 centimeter. We can do that in one scan. And if you have even larger breast, for some women, we can have the table, only the table be lifted, and the gantry stay at the lowest position. Then we can scan the anterior and the posterior. So there's a very minimal overlap between these two, so that we are not overexposed the breast, but we still cover as long as like 34 centimeter in the total length. That covers most of the women. So this shows how the coverage with a very small breast. This breast from the chest wall to nipple, that's about 5 centimeter. And you can see that we cover the chest wall muscle, the ribs, and there's a potential chest wall invasion of this lesion. And also we see some of the lymph nodes. And it demonstrates very good coverage for even the small breast in the population. Implant imaging. For implant imaging, KBCT, you don't need any special technique. Just same procedure, line prone, 7 second scan, and it collects the whole breast, including the tissue, including the whole implant. So there's no implant displacement or anything else. And also very important, there's no risk for potential rupture because of the compression. And there's data from FDA side that over 60% of the implant rupture is potentially be caused by compression, by the mammography procedure. We don't have that issue in KBCT. And so this is one of the implant patients. If we want to evaluate the soft tissue, and we can quickly adjust the window level, and we do have somewhere here. So there are presets. You switch to the soft tissue window level, then you can evaluate the soft tissue, find lesions, have small calcifications, things like that. And then if you quickly switch to another implant window level, you have the setting to evaluate the inside the implant. So all this is done just by clicking a button. If you go to MR, you need to go through a different sequence to acquire implant imaging like this. But in KBCT, and everything is collected in that 7-second scan. And some other consideration, there's a patient privacy consideration. And for some women, they probably don't feel comfortable their breast being manipulated during the acquisition, especially together with a painful scan and all this uncomfortable experience. For KBCT, sometimes the patient can even mount themselves, position themselves. So the interaction, I mean the physical interaction between the technologist and the patient is pretty minimal. And a lot of patients find that it's very acceptable. Contrast imaging. Doing contrast imaging in KBCT is very straightforward. And so this is a typical setup of the contrast imaging. We have the power injector, usually like dual syringe power injector placed on as the head side of the machine. And we have, so this is a typical injection protocol. Iodinated CT contrast media, 300 to 350 milligram per ml, and then using maximum 100 ml per contrast, and sometimes 20 to 40 ml saline chaser, and 2 ml per second injection speed. That's quite typical in the CT image acquisition, and a lot of hospitals, they are very familiar with this the injection protocol and their contrast administration protocol, and that's covered in their day-to-day practice. So that's also minimize the training procedure for sometimes say CT techs to do the contrast imaging of the KBCT. And we do have a scanning protocol set up. There are multiple scanning protocols available, and that's fully configurable. And generally, the pre-contrast scan injection and some seconds of delay and post-contrast scan, then you get the contrast enhanced image. So usually the patient comes in, and so here covered some of the question that we asked, when to use contrast. So this covers one scenario that the patient comes in for an initial diagnosis, and if we don't know any of the patient history, and we found some abnormalities. For example, in here we found a microcalcification cluster inside this very dense breast, and this is a good time that you may order a contrast. So once the contrast goes in, you may find this gets enhanced, and there are other enhancements in the different organ. So there are studies reported that, and I mean, think about this, compare this with MR. When you order a contrast for this patient, MR contrast scan for this patient, you probably still see this enhancement. And however, in CT, you have this calcification involvement that adds another parameter in your diagnosis. You have enhancement, you have enhancement pattern, you have morphologic features, you have the angiogenesis features, you have the involvement of the microcalcification. All this information gives a weight to your diagnosis. So all this can be acquired with just one pre-contrast scan and a post-contrast scan. The whole procedure lasts about 10 minutes for the exam. Then what's next? You have this contrast enhanced image. The patient doesn't need any more image. If she doesn't get a treatment, you bring this radiologist bring this same image to a surgeon, and we can do all this measurement as I just showed. The clock face location, the volume measurement, the distance between the lesion to the nipple, and if they plan treatment or like a surgery, that's only the last image in this workup is needed. In the previous workup, you may recall the patient again to do the breast MR in order for preoperative evaluation. For KBCT, that's only 2 images you need for this patient. So it's another case. We have the mammogram of the 44-year-old woman with a palpable mass, and so mammogram gives you some information, but not much. So when we use contrast imaging enhancement, speculated margin, and another multifocal enhancement in a different quarter. So this information gives you all the information that may happen inside this breast. Unfortunately, this patient went through a mastectomy eventually because of both of the lesions, both sides of the lesions were biopsied and came out to be IBC. For the diagnostic accuracy, so this is a study we carried, this is IRB-approved multi-case, multi-reader study, systematically compare the diagnostic accuracy between diagnostic mammography and KBCT. So we have 400 non-contrast KBCT, the same patient. It's a paired study with diagnostic mammography. The 220 contrast KBCT paired study with diagnostic mammography. 7 readers blinded with at least 2 weeks of memory washout period between the week of the same case. And here is the result. So the AUC, this is the AUC of a non-contrast KBCT, it's a contrast KBCT and a diagnostic mammography. The difference is larger than 0.05, which is proved it's clinically significant. And of course, we achieve the diagnostic, the statistical significance as well. And if we go to sensitivity, so this is 85%, with contrast it reaches about 93%, and diagnostic mammography is only about 77%. And specificity we are still higher than the DM. I have to point out that you may see contrast KBCT has a little bit lower specificity, and because this study was carried out in 2014, so at that time the doctors, the radiologists only accept about 1 week of how to read the KBCT. So once they see, at that time probably you don't see much of the contrast malware either. So once they see contrast, they see too much information to them. So they tend to rate every case and give a higher rate. So even so, so that's why you see a little bit lower specificity that compared with non-contrast KBCT. But however, even so, it's still higher than diagnostic mammography. Radiation dose, that's a question that has been asked all the time. It's a CT. Why can you achieve? Why do you say you have low dose? And so the KBCT, as I showed in the animation, you see that only the breast gets radiation, and the X-ray tube we use and the flat panel we use is all very low kVp. So the mean glandular dose of a KBCT scan is usually 5.8 milligram, which is within the FDA's screening mammography limit, and that's 6 milligram. And how does this compare with FFPM and DBT? So we put up this chart. If we compare the radiation dose, we have to compare in this whole workup. and we cannot ignore the diagnostic accuracy when we talk about radiation. There's always a risk and benefit. So initial visit, when the initial visit, imagine a patient gets a KBCT scan, so 5.8 milligray, and the patient may get a 2-view FFPM or a 2-view DVT, that's about 4.3 and 4.5. Then what's next? If the patient gets callback, then they need extra views for the FFPM and extra views for the DVT. Those all counts within a window of a couple of weeks. But in KBCT, you don't need extra imaging, so you need only one scan. So we are comparing this with this procedure, and we have 5.8 milligray, but in this it's between 9.5, it's 9.5 and 18.2 milligray for each of them. If they complete this, the 2 steps, and we are talking about the sensitivity and specificity that's higher than these 2. If in some cases you need a contrast imaging, and KBCT gets an extra scan, and that radiation dose is 11.6, and if we talk about contrast mammal, and that will add another about 5 milligray on top of this radiation dose. So we're still, then in here, the radiation dose is still lower than these 2, but we achieve the sensitivity and specificity that's close to a breast MR, not in this FFPM or DVT. So then we draw a chart. So this is the initial visit, that's the radiation comparison. And so the second step, we are lower. And if when they add contrast, we are lower. So this is for a small and average breast. And we do see that if for a larger breast, the initial dose will be higher. So if we have a large breast, and that's pretty typical for all modalities, you may need tiling in the FFPM or multiple views. And for large breast, we either use, sometimes we may use higher MA because it's bigger, and sometimes we may elevate the table to do 2-section scans. So, but even we do so, and the dose will be lower than the FFPM and DVT case. And then we have callback, then we add contrast. So that radiation dose, if we're talking about the whole workup, it's much lower than the other 2 modalities. And if the patient has implant, augmented breast, and we still do 1 scan, but in augmented breast, you need to do with the implant and displace an implant, and 4 views for 1 breast. And so that adds radiation dose, and then callbacks, then add contrast. So you see that in all this kind of scenario, initially there may be slightly higher for average and small average breast, but if we can consider the whole workflow, and we are overall the cumulative radiation dose is lower than FFPM procedure or DVT procedure. Image-guided biopsy, as you see in the animation. So that's how it's done. So this is the accessory we call a biopsy bracket that can be easily mounted underneath the table, and the grid and backplate and those needles are all supplied by the biopsy device company. We don't build that, so that's we provide image. So our software is configured very easily for the lesion localization and all these measurements. So once you select which lesion you want biopsy, these lines and these measurements are automatically done by the software. And instantly the software draw a red dot on the grid. So this is where you want to place the needle. And meanwhile, we have this mask. That depends on what kind of needle you're choosing. Different companies, as they may have different needle blocks, we make those masks. So you overlay this mask on top of here, so within several minutes, you already know where you want to place your needle, how deep you want to place your needle, then you can start the biopsy procedure. So once the channel is set, then this is a confirmation scan to make sure the obturator reaches the lesion location. Then you can start to extract the tissue. And usually, sometimes there will be a third scan after the tissue extraction to confirm the tissue extracted. In some sites, they skip this step because they are pretty confident that they acquired the correct tissue and place a marker, then confirm the marker is in place. So this whole procedure from beginning to end usually can take between 15 to 20 minutes with KBCT guidance. And of course, you can use this together with contrast, especially in the first scan. You use contrast that helps you to find the lesion easier, and then you follow the other scans to extract the correct tissue for pathology. And there are other applications that's been practiced in our clinical sites. There'll be neoadjuvant monitoring, and we provide the tools. I know, so you can measure at different stage of the chemotherapy the volume change as well as the diameter change. And so then at the phase 1, phase 2, and phase 3, we can measure the change in the volume. That can be another measurement of the tumor response during the neoadjuvant therapy. And needle localization, this is follows a very similar procedure as a biopsy. You just place the needle, and this is very useful for cases with microcalcification. So this is microcalcification, and we can accurately identify this lesion and place this needle right next to it. And for post-surgery follow-up, some patient, this is a lumpectomy patient. After lumpectomy, she basically refused to do any compression at all for the follow-up exam, and she developed some mass in her breast. So we took her to the KBCT, and we identified this mass, so that her feedback that is very comfortable, and she will never do any mammography exam. And so this is another case, as I just showed. This patient wants her clip to be removed, and so this is the only modality that could help her, because MR could not find the clip, and mammogram, there's nothing to compress, and ultrasound, without any guidance, ultrasound don't know where to look for. So she came here, and we got a very good coverage, and we found this posterior clip, and then she successfully gets removed. Well, that concludes pretty quickly the technical aspects and all the current applications we have been doing and have been done with Koning Breast CT. Yeah. Thank you.